Good morning, dear professors and colleagues. I'm Dr. Essam Sabah from Ibn al-Haytham Hospital, Cornea, Refractive and Advanced Cataract Fellowship. Today, I'm glad to be with you to present a Yamane intrascleral haptic fixation journey to climb up the hull. First, we all know there's a theory regarding the learning curve. It discusses the fact that the learner's efficiency in task improves over time, the more the learner performs the task. So it's gradually improving the process. But sometimes this is not exactly true, especially when dealing with steep learning curve issues. The real curve usually faces obstacles. These obstacles starting out with the first one when you start to learn a new process. First obstacle in the start, it's either that you are overconfident, so you will face complications, or you are afraid of obtaining new skills. This is the first one. Second one is prematurely. When you prematurely say that you have mastered this process, then you will lose your focus and you will get back into complications. Then if you analyze it and you provide yourself with the true weapons, then you will go gradually toward mastering the process. So it's not a real straightforward curve. So the hints or the tips to obtaining a new skill usually follow a step-ladder approach. You should be on a step-by-step climbing the stairs. Studying and watching videos will help you provide yourself with the appropriate weapons in your pocket whenever you need them. Allocating a mentor to be your target to follow. Of course, sensing the steps in a wet lab would be much more helpful. And finally, recording and self-review, because if you review your steps, you may improve the ones that are incomplete and you may maintain the ones that are properly done. Regarding Yamane intrascleral haptic fixation, it was first published in 2014 by Shin Yamane in Japan. It describes IOL fixation using needles to duck and externalize the haptic of a three-piece IOL, then cauterizing the tips to bury them into a scleral tunnel, and that flange will prevent the haptic from slipping back inside the eye. Of course, it is a well-known procedure, but it is usually faced with a steep learning curve. So to avoid that steep learning curve or to reduce the risk of complication, there are some tips and tricks to follow. The first is regarding the markings and incisions. Dry the conjunctiva. First start with is drying the conjunctiva before the markings will make your markings more clear. Use pointed instruments during markings to be more precise, and placing the main incision slightly to the left will help you place the trailing haptic easily. So you usually put the main incision to the dominant hand, but in Yamane it's better to be put at 12 o'clock if you are operating superior. These are the incisions which are 180 degrees apart, 2 mm from the limbus and 2 mm scleral tunnel on either side. Second one, regarding the needles. In Iraq we use 27 gauge needle. So tip of the needle, we should check the tip of the needle to be opened and sharp. And second one, bending the needle 70 degrees with a bevel toward the incision, and loosely attach the needles to the plunger, because later on you will need to dislodge the plunger from the needle, docking the leading haptic, and avoiding bubbles, because if you introduce the needle and there is some air in it, bubbles will obscure docking the haptics. So you should put some fluid inside the needles, prime the air before using the needles inside the eye. Also, proper anterior vitrectomy is mandatory. AC maintainer to keep the AC maintained and the eyeball of a normal tension to form a proper scleral tunnel, and gentle manipulation of the haptics. Especially in Iraq we deal with a three-piece Alcon PMA haptic IOL, which is not the mentioned by Yamane IOL, because they used a polyvinylidene haptic with a C-shape rather than J-shape haptic. These two problems, the design of the IOL and the material in the haptic, will make your life either easier or more difficult, because dealing with a PMA haptic J-shape is more difficult than dealing with a polyvinylidene, which easily, if it is king, it will return back to its position and it's hardly fracture, which is the opposite is seen with the PMMA haptic. Polyvinylidene. Regarding sterilizing the haptics, avoid conjunctival ballooning. Before you externalize each haptic, you should stop irrigation from the AC maintainer, because if you go out while the AC maintainer is on with fluid, you will cause conjunctival ballooning. This will obscure the burying of the flanges later on. Externalize the trailing haptic first, of course, because this will give you space, more ease, feasibility regarding the trailing haptic, which is more difficult. Flanges, check the centration before you apply cautery to the tip of the haptic. Avoid touching the haptic end with the cautery and bury the flanges well into the tunnel. And last, peripheral iridectomy to avoid the risk of ILP rise I found it mandatory, and better to suture the main incision to avoid any risk of hypotony postal. But what if the IOL is not well centered? First, you should check your markings. Are they 180 degree apart? Are the scleral tunnels 2 mm from each other? If they are not, you need to reintroduce the haptic back and reform a new scleral tunnel. If they are truly mashed, then the scleral tunnel length on either side is not the same. So you need to trim the side of the haptic that is shorter. And in this case, I'll show you, it's my number 6. As I'm in a learning curve of Yamane, today I almost reached 20 cases. This is my number 6. This is a young male with history of penetrating injury, corneal scar, and iris defect. Of course, this is my first mistakes. I'm using the marker rather than Sinski. It's a pointed material to mark more precisely. 2 mm from the limbus on either side, 180 degree apart, and 2 mm scleral tunnel also on either side are marked. The second defect is I'm not drawing the conjunctiva well, so we started with 2 mistakes by now, or 2 less proper steps. Making the main incision slightly to the left to ease docking the trailing haptic, forming the scleral tunnel gently. Once you feel that it's enough, you dive into. I usually apply the needle first, then inject the IOL, because I usually use Brian Kim modification to directly dock the leading haptic into the needle. And if it's not appropriate, it will help me keep the IOL into the anterior chamber. This is the first leading haptic, and leaving the needle in place, then going to the trailing haptic. You see that the trailing haptic, although it's J-shaped and long, but once the incision is on the left or at 12 o'clock, it is not long enough also. You see the bubbles. The bubbles we talked about because we have not primed the needles well. It will obscure your visualization. The third or the fourth mistake is I didn't stop the irrigation, so conjunctival ballooning has just occurred in the conjunctiva, which will make docking, burying the flange more difficult. This is the trailing haptic externalized, then the leading one. Here I stop the irrigation. Then checking the centration. The fourth mistake is it's slightly shorter tunnel on this side, so I need to trim it on this side to be more central. The problem also, the last problem in this case is an iris defect, so an iridoplasty sutures to make things much better. 2 are done superiorly, and the last one is done inferiorly to conclude the case. Of course, a sliding knot is used to obscure, to secure the knot inside the eye, and then using micro scissors to cut it. And thank you very much.